I'd like to welcome you all to our webinar tonight. We're going to talk about erectile dysfunction, which is a pretty common outcome from prostate cancer treatment, or the various sorts of treatment. And I'm Graham Woodside from the Prostate Cancer Foundation, along with my colleague Raywin Pavia, who's our National Support and Education Manager. We're going to be hosting your webinar tonight. We're pleased to do that. I also just want to issue a sort of a warning typical of explicit TV programs, that tonight we're going to be talking quite frankly and explicitly about some sexual issues. I hope this will be informative, and attendees and future viewers of this, because we're recording it tonight, that people are not offended by this. It's all in the interest of improving quality of life for men and their partners who are living with prostate cancer. So let's get underway. I'd like to introduce our presenters for the evening. Firstly, Urologist Giovanni Losco, and the physiotherapist is Sharon Wilson. So I'll tell you a little bit about them just by way of introduction. Giovanni joined Urology Associates in Christchurch after subspecialty training in Australia and the United Kingdom. And in 2018, he was awarded a travelling fellowship where he spent time in the USA operating with world-leading surgeons in erectile dysfunction. He's the clinical director of urology at Christchurch Hospital and also works out of the Burwood Spinal Unit in Timaru Hospital, as well as working in private practice. Sharon completed her bachelor degree in physiotherapy at Otago University in 1999. In 2000, she and her family moved to Kalgoorlie in Western Australia, which is where she developed a special interest in continence and pelvic health. In 2010, Sharon and her family returned to Nelson, where she set up her business Restore Physio. She's since completed her master's in clinical physiotherapy. So both Giovanni and Sharon are very well qualified and experienced to be bringing us the webinar. Giovanni, I'd like to start off with you by asking, what's the connection of the prostate gland has to erectile functions, and why, when men are treated for prostate cancer, that function is adversely affected?
Thanks, Graham. And thanks for inviting me to be part of the webinar. Thanks for everyone to joining us. Look, it's a really good question. And I think before I just answer precisely why it is that prostate cancer and prostate treatment causes erectile dysfunction, I just want to take a step back a little bit, because a lot of men, unfortunately, start their prostate cancer journey already with a little bit of erectile dysfunction. So a lot of men, unfortunately, due to a number of processes, start the journey of prostate cancer with some problems with their erection. So the blood vessels to the penis are some of the smallest and narrowest blood vessels in the body, and the same problems that cause heart attacks and strokes and what we call hardening of the arteries also affects the penis. So when you're young, you've got these nice big vessels here on the left. Then as you get a little bit older, due to things like diabetes, high cholesterol, high blood pressure, smoking, those arteries narrow up and the blood just can't get into the penis as good as it used to. And if the blood can't get into the penis, you can't get a good erection, because erections are all about having a penis which is full of blood. So all of these things here, keeping salt out of your diet, keeping control of your blood pressure, cholesterol, that's all really important for having good erections. Now, unfortunately, if you've already lost a degree of erection, nothing is going to make them come back again entirely naturally. So later on tonight, we'll talk about some of the treatments, but if the damage has been done, that will kind of be as good as you expect your erections might be after treatment for prostate cancer. So the question really is, what is it about treatment for prostate cancer that causes erection problems? And it really comes down to this. So what this diagram is showing you is the bladder is this yellow circle here, and the prostate, Graham, is my cursor showing on the screen?
Yep, yes it is.
Yeah. And the prostate is this little organ in the middle, and then the urethra, which is the water pipe, the tube that carries urine out from the end of the penis, is here. And what these blue things are the nerves. So these nerves are the nerves that supply erections, and they run extremely close to the prostate. And when you have to have your prostate removed for prostate cancer, by necessity, these nerves are going to be either deliberately removed. So imagine if your cancer is sitting right here by one of these little blue things, and of course, unfortunately for surgeons, they're not actually color-coded inside the body. If your cancer is sitting right here, then those nerves are going to have to be removed, and that's really going to affect your erections. On the other hand, sometimes surgeons can do an operation to spare the nerves, so they deliberately try not to actually remove the nerves, but they are still going to get a little bit injured and a little bit damaged. And you can see in this picture here, this is where the prostate's been removed. The surgeon, the urologist, is going to close those ends together again, but these nerves are going to get a bit of a shock. So that's with surgery. Again, this is a picture inside the body. This is a robotic removal of the prostate. This is showing the nerves very, very nicely. The reality is this has been done by an artist. When the surgeon's actually in there, they're not seeing these beautifully colored like this. That is how close the nerves are to the prostate. The nerves that supply erections, we call that the neurovascular bundle, very, very close to the prostate. In radiation, the same issue arises. So even though the prostate's not being physically removed, those radiation beams that are being sent into the body to target the prostate, some of those get scattered in the vicinity of the prostate, and they also affect the nerves and cause some damage to the nerves. The other thing I want to mention is that some men are having treatment for prostate cancer that's not surgery or radiation. They're on hormone treatments. And okay, this is a little bit of an old slide because this drug, Leukerin, is not funded by Pharmac in New Zealand anymore, but Zoladex is the one that is. And that's a drug that actually removes or lowers the testosterone level in the body. Testosterone is the male hormone made by the testicles, and you need testosterone to get erections. This drug removes the testosterone. So that's another way, but a different way of how erections are caused by prostate cancer and prostate cancer treatments.
Okay, so what's the time frame? I guess with surgery, it's going to be pretty much immediate that it's going to take have some effect. What about the radiotherapy and the hormone therapy? Is it going to be a fairly instant effect, or is it going to be a cumulative effect?
So surgery and radiation are quite interesting in terms of when the side effects arise. The side effects from surgery are worse straight away. So day one after the surgery, even with the best surgeon and a nerve-sparing operation, I wouldn't expect you to have normal erections. And if you do, you're very, very lucky. It does happen, but it wouldn't be expected. With radiation, often it can take some weeks or months for the problems to come, and sometimes even years. And that's because the effect that the radiation has on the tissue kind of lingers, and the damage can go on and on months or years down the track. Whereas with surgery, you tend to start to see improvement. It tends not to get worse after the operation's happened.
One of the issues that I hear often from guys is when they're considering their treatment, and they often ring us on our 0800 number to have a chat about these sort of things, they didn't fully understand or appreciate that this is a potential side effect from their treatment. Do you want to comment on that? How do you deal with it when you're dealing with patients?
Yeah, well, I think it's our duty as clinicians to tell men that erection problems can happen after prostate cancer. I think the reality of it is when you're hit with a diagnosis of prostate cancer and you're thinking about, what the treatment entails, is a whole lot of things to think about. If you're thinking of radiation, it could be 4 to 6 weeks of having to travel to another town in the country to have that treatment. I think sometimes that thinking about your erections, it doesn't really seem like the most important thing in the world to you at that point. Sometimes you're just not really, maybe really engaged about worrying about that. And it's only once you've been through the treatment and everything's gone well, hopefully, and you're doing well, and you realize, I really didn't think so much about the erections. And I think every urologist is different, and every radiation oncologist is different. And I suspect that not everyone is maybe as open as perhaps we should be about talking about erection problems. But to a degree, it's also we're trying to impart that information about the diagnosis of cancer. So it's getting that balance right can be difficult.
I might just mention, we've got a little booklet with a whole lot of questions that you should ask your clinician when you're going through a diagnosis and deciding on treatment, and that's available from the Prostate Cancer Foundation. And it's got little spaces to write things down and that, so you can take notes when you're actually having a consultation, because we find that a lot of people actually don't hear all the conversation about some of these things, as you say, because they're focused on actually getting rid of the cancer and not some of these other things they may have to deal with. So as a surgeon, just explain a little bit, when you're actually doing the surgery, what's the process you go through to actually minimize that damage? You talked about nerve sparing.
Yeah, so as you saw in that picture before, the nerves are extremely close to the prostate. So when you're having an open radical prostatectomy, so that's one made with a big cut, 7 or 8 centimeters below the tummy button, you're relying on the human eye, essentially, and often surgeons will have some magnification to help them find that fine layer where the nerves are, and to very carefully and slowly peel the nerves off. Remember, that's for the nerve sparing surgery. Some men need to have the nerves removed in order to cure the cancer. But for the nerve sparing surgery, that can be done. With the robotic surgery, so that's a keyhole type of operation. I'm sure many of the men viewing this tonight will have had that procedure. The advantage of the robotic surgery is the surgeon is actually sitting at what we call a console. It's sort of like a big TV. And there's a camera inside the body, which can really create a very high degree of magnification, so they get a much better view. Now, the evidence out there is not that strong that robotic surgery is necessarily better for erections, but it suggests that it probably is. And it makes sense. You can see better. You can find those nerves. It probably means there's slightly less trouble with erections.
Okay. Is there anything that men can do ahead of, they're considering treatment, so ahead of their treatment, is there anything that they can do to increase their chances of erectile recovery? For instance, there's suggestions been made that taking a course of the blue pills, the Viagra type pills, the PDE5 inhibitors taken in the lead up to treatment, that those sort of things can help. Any comments on that?
Yeah, Graham, there is. There is some evidence that certainly helps. As I said earlier, your erections after surgery will never be better than the ones you have beforehand. So it's kind of a case of use it or lose it. If you're having good erections and you make use of them, and the PDE5 inhibitors, the tablets like Viagra, Cialis, etc., using those to help improve your erections beforehand, it will improve your ability to get erections afterwards.
We'll talk a bit more about those later on when we talk about some of the treatments and things after surgery as well. Sharon, let me just bring you in here, physiotherapist. You're seeing men who've got erection problems, but what about beforehand? Is it worth coming to see a physiotherapist beforehand? What can you help with pre-treatment?
Thanks, Graham, and hello to everyone, and hello to all those people that I've met during the conferences over the last 4 years. I'm sure some of you have come to my booth. So I think as a physiotherapist, one of the key factors is pelvic floor exercises before you head for prostate treatment. So there is very good evidence that if you can get your pelvic floor muscles stronger before you have treatment, that is strong but also coordinated with better endurance, you get the technique down, your brain and the nerves find those muscles, and they're going to be a lot stronger and willing to move after having treatment. So finding a pelvic floor physiotherapist to lead you in finding those muscles and doing it accurately is very important. Also, I think looking at diet, so making some dietary changes before surgery could be beneficial. So maybe seeing a dietitian and looking at what's healthy, what could you change in your diet. Exercise has been proven to be just a gold standard for cancer treatment. So looking at improving how many times you're walking, looking at maybe getting a personal trainer, looking at what exercise you enjoy and how can you bring that into your day so that you're already in a bit of a pattern of exercise is really important. And then maybe not using vacuum pumps yet, like we've talked about, but Giovanni hinted at actually, if you are sexually active, then actually enjoying sex leading up to your prostate cancer treatment, maybe indulging in it if you want to, and just giving your penis and your penile health and the blood and the nerves lots of exercise.
Okay, that's good. Okay, let's move on to a little bit about following treatment. Giovanni, sex won't usually be on the agenda immediately following surgery, but what's a realistic expectation for men when men should get an indication of how they might be affected in the longer term?
Yeah, look, it is actually highly variable. So usually you're not really thinking about it to begin with. You've got a catheter in the penis. Actually having an erection is uncomfortable, painful when you've got a catheter in for the week or two after surgery. What you'll start to notice, hopefully, in the next few weeks is a little bit of a flicker of activity down there. So something sort of happens. It's not what it used to be, but something's happening, and that's a really positive sign. If you're in the group of men that have had their nerves removed, so what we call a non-nerve sparing operation, we really don't expect you to have a return of erection. Some men still do, which is a bit of a miracle, but it can happen. So if you're getting a bit of a flicker of erections, that's really promising after the first few weeks, and that will be a good time. We'll talk about this later, but this is a good time to sort of harness that and start the penile rehabilitation. The way I explain it often is if you put your back out after a short period of rest, people are encouraged these days to exercise and to use it rather than just lie in bed for 6 weeks. It's the same thing with the penis. You actually want to use it and try and get it back to activity.
And the same would go for radiotherapy and other non-surgical treatments as well.
Yeah, it's a little bit different with radiation because that time course changes a little bit. So often when you have the treatment, things are okay. It's not for a few weeks or a few months down the track that you start to notice a difference. And it's whenever you start to notice that problem that you want to really embark on the techniques, the exercises, the pills, whatever to try and help.
Now, I know, all men in all cases will be different, but do you have some data on the level of the time of recovery across a number of sort of patient studies? What's realistic?
Yeah, so I talk about the rule of thirds. Sure, I talk about the rule of thirds with surgery. So if you're having a nerve-sparing operation, a third of men should expect to get what we call normal erections. A third of men will get erections, but they'll need to use something to help, whether it's drugs or vacuum pumps, etc. And a third of men still won't. The time frame for that is generally variable. If you are noticing a continued improvement, then it's best to just, carry on watching that improvement happen. Generally, by a year after the surgery, you should have a pretty good idea about how things are going to go. If they're not looking so flash, to improve your chances, you want to be getting onto it much sooner than that, though.
Sharon, some comments?
Sure. So as a physiotherapist, I'm pretty proactive on penile health and penile rehabilitation. So what we mean by that is that before you have treatment for prostate cancer and you were sexually active and you were pretty healthy down below with erections, your penis practiced through the night, and it's like it was exercising for you. So it's called tumescence. So 3 to 6 or so times a night, your penis would expand. You'd wake up in the night and there was your penis erect. You wake up in the morning and there it was. And what that's doing is it's stretching. It's trying to keep its length and its girth. And after having prostate cancer treatment, what happens is that penis stops exercising. So what you're at risk of is what we call fibrosis. So the tissues within the penis become hardened and they don't flex as much. So using penile rehab is really important to keep the penis healthy again. I guess it's a bit like breaking your arm and not moving your arm again and giving it a time to bounce back, but actually you need to exercise it and stretch it. So to me, penile rehabilitation means stretching the penile tissue in the shower. So spending a bit long cleaning it, massaging it, stretching it out, giving it the warmth that it needs to encourage blood supply in. It also means pelvic floor exercises. So if you've been told that you need to squeeze and lift like you're holding on to wind, I would encourage you to potentially tweak that a little bit. I've just got a model here. So if you're squeezing like you're holding onto wind, what you're going to get is a really good squeeze around the back passage, like you're holding onto a fart. But actually, we know that the best treatment is to work these muscles at the very front of your pelvic floor. This is the prostate here, and this is the pelvic floor that goes right underneath it. So when you have this removed or have treatment for it, it's these muscles that get themselves into trouble. and cause some weakness. So the key for pelvic floor exercises is lifting your nuts to your guts and shortening your penis. So several studies have been done. That is the cue that targets those front muscles. And what it does is it tries to get a sliding action between the two layers of the pelvic floor with the urethra through the middle, and to try and get a kinking action. So nuts to guts is your new form of verbal cue, and shortening your penis. We don't want lots of anything else moving. We don't want your upper tummy pulling in. You're allowed to get a gentle tuck through your lower tummy would be fine. So that's your next cue. We want your marathon runners to be exercised. So you might want to hold for up to 10 seconds, relax for 10 seconds, maybe repeat 10 times if you can do it. But we also want your sprint muscles, your Usain Bolts of your pelvic floor to work really well. They're the ones that are going to help you maintain an erection, help you with a strong orgasm effect, because they're the muscles that contract. So you would lift them, drop them, lift them, drop them. So if you stood in front of a mirror, you should see your testicles squeeze, lift, drop down. And if they're doing that, you're totally on target and you're doing super well. And as part of penile rehab, you've got exercise, you've got looking at your diet, and you've got reducing smoking as you can, and then things we're going to talk about later on, like PDE5 inhibitors, injections and pumps and prosthesis.
Great, thank you. I'm sitting here doing a bit of squeezing myself while we talk.
I was hoping some of you would be.
Yeah, it's good to have you explaining it so well. That's good. Look, just a reminder that we do have this facility for questions. I notice, Raven, there's a couple of questions there.
Yes, we have. The first question that's come in is quite a long question, but here we go. This gentleman is asking, do you agree with the research document Margins to Mainstream by Global Action on Men's Health Research Group? Stigma can have a significant effect on the equality of men's lives following a diagnosis. The impact of the disease on men's sexual functioning and their continence can be experienced as particularly shameful. These feelings are a barrier to many men taking on an advocacy role. Prostate cancer study, and then there's a reference, and if anybody's interested to that reference, we can send it out. Giovanni, would you like to make a reply to that?
Oh, look, I think it's very true. I think that prostate cancer, because of the intimate nature of the condition and the side effects, incontinence, sexual dysfunction, is something which as a society we shy away from talking from. It's very much embedded in the Kiwi culture, as men don't talk about these kind of issues. And I agree, and I think it does act not just as a barrier to taking on an advocacy role, but actually in seeking treatment and in seeking help. And I think the people that come and see myself and come and see Sharon are actually the brave few that pluck up the courage to do so. So look, I think it's very real.
So another question from this gentleman is, what effect does a Resume procedure have on erections? Thank you.
So the Resume procedure is not really a treatment for prostate cancer. It's a treatment for BPH, so big prostates, so slightly outside the scope of the forum, but I'm happy to comment. I mean, essentially, it's a new procedure. It hasn't been around for very long, like all the treatments for big prostates. So this is men with poor flow, like can't wee very strongly, as opposed to cancer. Like all of those treatments, they all have very low effects of damaging erections, but it's a pretty new treatment, hasn't been around very long. Very hard to know what those men will be like in 10, 15 years down the track. Mm-hmm. And no one can really answer that. It's just a new treatment.
Okay, thanks, Raven. We're going to talk about some of the devices and the treatments for dealing with erectile dysfunction. Let's start with the obvious one, with the blue pills, the PDE5 inhibitors, the Viagra type pills. Because one of the things that we find men complaining about is the cost of these and the cost of other devices that are available. Unfortunately, in New Zealand, none of this is funded, unlike the NHS in the UK, where a lot of it is funded. Any suggestions for getting lower cost access to particularly the pills, Giovanni?
My main message here is they're not funded by the government. So essentially pharmacies can charge what they like. Funded medications is a $5 script fee. It's not the case for non-funded medications. So pharmacies can charge what they like. And so the message is shop around. Different pharmacies in your own town will charge different amounts. So just because your pharmacy that you've always gone to for your regular prescriptions seems to charge a lot, try the pharmacy around the corner, try somewhere else. There are also the big pharmacies like Chemist Warehouse. I don't actually know what they charge, but there's a potential that they may charge less prices. I know in Christchurch, there's a couple of pharmacies that people in the know go to because they tend to be a little bit cheaper. So don't just accept the cost of the pharmacy that you always go to.
Yeah. And also beware of ordering from overseas, right?
Yeah, that's true. So I'd very much caution online pharmaceuticals because you don't actually know what you're getting. It may have Viagra on the box, but it may not be Viagra inside.
Yep. Let's project sort of forward 6 months, 12 months after treatment. What should be happening by that stage in terms of recovery of erectile functions, and how should men and their partners manage realistic expectations about penile recovery?
So I think by 6 months, you should be starting to get a feel as to which direction things are heading in. Probably around 30 to 40% or 30% of men that have had nerve sparing surgery are starting to get erections, which are, pretty good. Probably 10-15% of men by that stage are getting good erections, they can use them. By a year, you'll have a very good indication as to whether things are going to be working for you naturally or whether now would be the time, if you haven't done so already, to start looking at some other treatment options.
So let's take the scenario that I guess a lot of men face, it's at least a third, based on what you've been saying, that at 12 months there's minimal or there's no function getting an erection adequate for intercourse. And the reality is starting to sink in and it can be quite depressing for men and their partners. So let's discuss some of the options now that we've got for assisting erectile dysfunctions when it's just not happening naturally. So Sharon, you've got some devices there you'd like to show us and talk about.
I have. I think the key thing with penile health and penile rehab is earlier the better. So I encourage my patients, once the catheter's out, to start thinking about using a pump and getting that blood flow, getting that excitement within the penis. Also, looking at going on your PDE5 inhibitors. If you're on a low dose every day, I talk about it like a multivitamin for your penis. And then if you have the higher dose ones, it's more like a double shot of coffee, trying to get that stimulation happening. So I think they're really good. So vacuum pumps take over that expansion that normally happens through the night, like where I was talking about before, that tumescence. If the penis doesn't expand, it becomes stiff. And so if your erections do spontaneously start to return about the year or even 2 or 3 years later, and your penis hasn't been expanding, it's stiff. And we all know that the penis does shorten after prostate surgery, and the average is actually 1 centimetre. It can be as much as up to 4 centimetres, but the average is 1 centimetre shortening. So to take over that penis exercise that it does through the night, you can use a pump. So what a pump does is it brings blood supply into the penis. This is a very basic one from my website that I sell pumps from. This one here is just a very simple one. Use a hand trigger here. The penis goes into the end. I'm just going to get my penis out here. Very unglamorous. You do what you've got to do. The penis sits at the entrance here. As you pump, the vacuum creates a negative pressure and the penis will get sucked into the pump. The blood will then increase within the penis and you'll get a simulated erection. Now, it won't be the same type of erection as if you naturally had them, because you and your wife were having a bit of foreplay and the chemicals were actioning and the penis naturally with that the cavernous nerves started to get an erection. But what it's doing is it's exercising the penis. It's pulling, we know from studies, it's pulling both arterial blood and venous blood. So veins and arteries are involved in the process, and the penis expands so that when your erections return, the penis is healthy. It's got its length, it's got its girth. You recognise it. Your penis. It's the same as before. This is a different type of one. Again, this is quite a long one. Don't be intimidated. Again, this one is slightly different in that you push a button and that creates a vacuum. They come in, honestly, they come in so many different sizes and shapes. This is called a bath mate. So a bath mate generates a lot of pressure. The penis goes at the entrance here. There's the penis. It pushes up against your body, and as it pushes up against your body, the bellows create the vacuum. It's got a one-way seal on the end valve so that the air escapes but then doesn't fill again. A really nice one for the shower or the bath because heat is good for the penis to get it excited as well. And so that's penis pumps or vacuum erection devices. There are other ones out there that are more medical. I now sell one called VacuRect, which comes with a constriction ring system already built into the end of the pump, so that your penis goes in and it's already got a constriction device around it. Kind of, I'm just going to pull this one off. Kind of like this type of a thing, so that the penis goes in, and when it's erect, you peel it off and it's already on your penis. Therefore, if you have a problem with getting an erection, but it doesn't last as long and it goes down, what that could be is weakness of your pelvic floors. So nuts to guts is your practice one for that. But it can also be that the blood is leaving the penis via the nerves. And what normally happens is the veins get, via the blood veins, they normally get squashed up against the side of the penis and they can't empty, and that's why you can maintain an erection. So constriction devices to stop that happening come in all sorts of shapes and sizes. This is one called Dr. Joe. It looks, if you're a farmer, you're probably squinting right now and feeling quite squeamish. So it's very similar to the docking system. So with all constriction rings, don't leave them on for longer than 30 minutes. Please don't go to sleep with them on because things could look very different in the morning. So that one is just a toggle system which stretches onto the base of the penis to hold it on. This is one called an Osborne tension ring. It's a medical-based one. You can see these bumps at the top. Because the veins are at the top of the penis, they put pressure on it to really put more emphasis on stopping the blood supply leaving through the veins. And then you've got another one here, which is a very simple, squishy one. So if you only need a little bit of extra tension, you could play around with a ribbed ring as well. Latest device is a vibrator for men. So the pumps work on penile health, blood supply, expanding the penis, whereas this works on the nervous system. So we know that the penis really responds to vibration via nerves. And so I'm going to turn it on. So these little wings vibrate. So we know that also at the end of the penis, there's some really strong nerves that like attention. So if you put your penis in the end of this, you're going to stimulate those nerves. You can also put it at the base of the penis. Again, that's a real central area for men. And it goes up and up. And honestly, it almost sounds like it's going to take off when it really gets itself wound up. And there's different settings as well. Then with lubricant in it, this is the R18 part of the talk tonight. You can slide it up and down, and you can see that there's ribs along it. So what you're trying to do is you really are trying to give your penis the best chance of stimulation, arousal, response, and encourage you along the way. You can have an orgasm without an erect penis. So if you get those nerves stimulated, you can still enjoy the sensation of an orgasm, and it's something that you and your partner could aim for together.
Thank you. That's That's a good
You're
choice.
right, Graham.
Yeah, that's marvelous. Giovanni, any comments on those?
Sharon, I was just wondering whether you sell those bananas on your website as well.
Look, I don't, but if urologists start to want them, I'm willing to see if I can find a stockist.
Yeah, it's quite nifty. And in all seriousness, though, do men find any of those devices painful or uncomfortable?
So certainly not the vibrator. I've had lots of very pleased people. But the thing with the pump is you must start slowly. So if you get too excited and go, oh my gosh, I haven't seen my penis expand for several months, and you keep the pressure on, it's going to build and build. And so what can happen is it can get painful because the blood really rushes in. You can get what we call petechial bleeds, so little blood bleeds within the penis, and it can feel bruised and really swollen. So what we recommend is that you pump to about 50%, you hold it for 2 to 3 minutes, you let it go down, and then you pump to 75 and down and 100% and down. And so for some men that takes several days to get used to the pressure. I've had one man that got so excited because he was 4 years on and he had no erections because he had his nerves taken out, and he actually sucked one of his testicles up into the pump. And I shouldn't probably be telling you that, but on my website, and I give an information sheet with every pump I sell, it says please go careful. The key also with a pump is that you want a really good seal between the end of the pump and your body. So lube on the pubes is really important. Some men have to trim the pubes so that there's a really, really good seal as well, and use lots of lubricant. You can use a pump with medication. You can use a pump before and after injections as well, so they can enhance what's already happening to get the best erection you can aim for.
Okay, now there's a number of questions there, but we're just going to get one more comment from Giovanni, and then we'll do a whole lot of questions together. I just noticed somebody was putting their hand up. As I said earlier in the evening, please don't use that function. If you've got a question, if you want to direct something to us, please use the Q&A option at the bottom. Giovanni, let's talk about some of the medical options for ED. We've talked about the blue pills. Let's talk about the injectables and some of those other things.
Sure. Now let me just try and do this little thing again. Is that Sharon?
It is, yes.
Yeah. So I can talk about a ladder of options, and there isn't necessarily a right order in terms of pills versus the vacuum pumps and physiotherapy. So if you think about the non-medical things like vacuum pumps, physiotherapy, then there's pills, then there's injections, and then there's what I call the top shelf, like the top shelf at the bar, which is the most expensive stuff, but also the best, and that it's the most effective. So you've got your tablets to begin with. So Viagra is a trade name. It's made by a company called Pfizer, but the drug is called sildenafil. So these days you'll find cheaper versions of sildenafil out there. So one thing I suppose to point out, it probably just flows into your question earlier, Graham, is that if your doctor or GP specifically prescribes Viagra, it will cost more money. So you want them to actually prescribe sildenafil. It's the same drug, you can just get a cheaper option. Cialis is another brand. The actual drug is called tadalafil, and Levitra is a further brand. The actual drug is called vardenafil. And what these drugs do, sort of simplistically, is they basically make the blood vessels into the penis dilate up, so more blood can get in there. They allow more blood into the penis, and that also has the effect, the way the penis is structured, as those vessels that allow the blood flow to get in get wider, the vessels that allow the blood to come out get kind of squished, so it keeps the blood inside the penis. And all three drugs work in very similar ways. If you find that one drug isn't really working for you, it is worth trying a different one. So just because sildenafil hasn't worked doesn't mean that tadalafil won't work. It is worth trying a different one. And people can get slightly different side effects. The only one which is what is known as a generic is sildenafil. So if you get prescribed tadalafil, it will only come as Cialis, and that does make it more expensive. One of the little comments to make about Cialis is that this drug is available as a low dose. So this is a 20 milligram tablet pictured here, which you just take when you want to have sex, but it is also available as a 5 milligram tablet, and that's designed to be taken every single day, once a day, every day. So you've always got that background level of Cialis in your system. You can use it for intercourse, and it helps with that kind of rehabilitation. In terms of taking these tablets, there's a few tips. It's not just as simple as popping a pill and getting an erection. You do still need some sexual stimulation. So your partner, masturbation, vibrator devices, etc. They're needed as well as the tablet. They don't work as well after a big fatty meal. They're just not absorbed as well. And depending on which drug it is, you need to allow at least 30 minutes to 1 hour before sex. For sildenafil, which is Viagra, you really need to allow an hour. Cialis could be slightly shorter. Now, if you do try the drug for the first time and find that it hasn't worked, don't give up on it. Some good evidence that you should try it at least half a dozen times, and you should make sure you're on the maximum dose. So Viagra is available as a 25 milligram, a 50 milligram, and also a 100 milligram tablet. So just because the 50s don't work, do make sure you're using the 100 milligram. And on the note of saving money, it's cheaper to get prescribed 100 milligram tablets and cut them in half than to be prescribed 50s. So if you find that 50s work for you, get your doctor to prescribe you 100s and just cut them in half. And as I say, if one drug hasn't worked, do try another tablet as well before you particularly give up on them. Can cause some side effects. The most common ones are feeling flushed and a headache. Some men get back pain. Some men find their vision goes a bit blurry. Some describe a really stuffy nose and even a blue tinge to the vision, which is a little bit unusual, but they're all described as side effects. And just because, for example, Cialis causes side effects doesn't mean that Viagra will. So yeah, it is worth swapping over if you're getting side effects. So once we moved on from the tablets, if you have tried the full dose 6 times and it hasn't worked, the next thing to try is the injections. This little slide, just a reminder what we said before, please don't buy things on the internet. They might seem cheap, but it's usually a case of it's too good to be true. Vacuum devices, Sharon's covered. So injectables. So you have a medication called Cavaject. That's the only one which is very easily available in New Zealand. And the reason I say that is it's a drug called L-Prostadil, which again is a medication that helps to dilate those blood vessels. It comes in a syringe, which is a little thing attached to a needle, and you inject it directly into the side of the penis. So this little picture in the top right corner here, that's a cross-section of the penis. Imagine you just chop the penis in half. This is what it looks like in the middle. These two big circles, looks a little bit like the eyes of a bug, like a fly. These two vessels here are what fill up with blood and cause an erection. And you put that needle just into one side. It's not as bad as it sounds. Unsurprisingly, a lot of men aren't particularly keen on this idea. It's very similar, though, to people that have diabetes and need to inject themselves with insulin. It's a very small needle, goes into the side of the penis. That medication then gets directly into the penis and allow those blood vessels to dilate. There are some other medications which are less available these days because they have to be actually mixed up manually by the pharmacist. Once upon a time, before my time, that was commonplace that pharmacists would be mixing up drugs in their back room. It's pretty uncommon these days. There's just a few pharmacies around the country that do it. I think there's one in Tauranga that does it. And actually mixes up these drugs, and they're a bit cheaper as well. And I believe the Tauranga outfit can send them around the country. So that's an alternative. But you dial up to that 7.5, that's milligrams, and you can go up to 20 milligrams. That will be the maximum dose. One of the risks with these, they tend to give good erections, but they can give erections that are so good that they don't go away. And that is actually just as bad as it might sound. So if you have an erection that doesn't go away, that can eventually cause you to have even worse erections. They're painful and you need to take yourself to the emergency department. So it's not something to try without a little bit of good education about how to use it. And then finally, that top shelf is surgery. So these are implants which are placed into the penis. There's really 2 brands which are available in New Zealand. One is made by a company called Coloplast, and it's been given the very strong name of Titan. And then the other one is made by a company called American Medical Systems, or AMS, and it's called the AMS 700. It's actually now sold by a company called Boston Scientific. Both of these devices are fundamentally the same in their design. There's two cylinders, these big white tubes that are buried inside the penis. There's this sort of star-shaped structure which is filled with saline or salty water, and that's buried inside the tummy cavity. Then there's this little bit here, a little pump, and that sits inside the scrotum like a third testicle. So this all looks a little bit alarming and dramatic, but it is all entirely buried within the body. So this picture here shows you those two tubes that are inside the penis, the reservoir, we call it, which is filled with the salty water in the abdomen or the tummy, and this pump inside the scrotum. And this shows you how it works. So basically, when the penis is flaccid, this reservoir is full of salt, full of salty water. When you want to get an erection, you pump the pump. So you do that with your between your thumb and forefinger. You physically pump the fluid, and that takes the fluid out of this reservoir and fills up those cylinders or tubes inside the penis, and that gives you an erection. Once you've finished, there's a little button on the side. It's not particularly well shown there. Little button, you push that button, and the penis goes back to its flaccid or floppy state again. This is a very short video that just demonstrates what's going on. I'm assuming that's displaying well for you.
Yeah, fine.
So you can see this man here is just pumping the pump, and just shows how that the cylinders are inflating and giving a good erection. And I don't think it, well, yes, that's going to show him just pushing that button once he's finished, and then just give the penis a very gentle squeeze, and that just allows that fluid to come out again. So once you've had the surgery, you're going to get good erections, but you can't go back. So you can't go back to using tablets or vacuum pumps or injections or so forth. It is a mechanical device, so like your car, it's prone to breakdowns. If it has a breakdown, it needs a service. If it needs a service, that does mean another operation. There's about a 10% chance of needing another operation in a 10-year period. So if you have one of these put in, 10 years down the track, 1 in 10 men will have needed another surgery because something's gone wrong. Maybe the fluid's leaked out, part of it is broken. The worst thing that can happen is getting an infection. The device is made from plastic. Antibiotics can't get into plastic. So if the device gets infected, the whole thing has to be removed. Fortunately, that's very rare, but it is a real catastrophe if it happens. So we do a lot of things to try and reduce that risk. The AMS 700, the other company I mentioned, they were actually the original device. Coloplast sort of copied it. The concept is exactly the same. The reason this device is orange or yellow is because it's actually got an antibiotic impregnated or built into it to try and resist that infection. Either device is, I couldn't say one's better than the other. They both effectively do the same thing. Complications I kind of talked about. Infection really is the enemy. Like your car, occasionally the wheels can fall off.
So Giovanni, the inevitable question is, what's the cost? Somebody sure want to know that. Injectables, because they're not funded, the Cabajet, do you know what the cost is?
Yeah, so the cost of injectables, again, just like Viagra, shop around.
Mm-hmm.
They are expensive though. I think pharmacies around me are charging $50 or $60 per injection.
Right.
The devices are very expensive. So the Coloplast Titan is, I think, around $15,000. That's just for the device. The AMS 700 is a wee bit more than that, sort of $18,000 to $20,000, I think. And as I say, that's just for the device. The cost of the operation, the cost of the anaesthetist, the surgeon, the hospital is on top of that. And unfortunately, it's not funded in the public health system, and very, very few insurance companies will fund it. There tend to be some men that have very old policies that will fund it, but most of the policies being written by the insurance companies these days have erectile dysfunction in the fine print as something which they just, is an exclusion, unfortunately.
Why are the medications and devices not funded? Would lobbying help?
They're not funded, that's right, and we have made some noises about that. There is a current process, I don't want to go into a lot of detail, but there's a current process going on looking at the whole treatment program for prostate cancer, and this issue is being included in that. And that is currently being worked through with the new cancer agency. I don't hold my breath about that. But it's certainly something that the foundation is pretty active in trying to advocate for when we get an opportunity to do that.
So the next question is, there is conflicting research on whether testosterone replacement therapy for hypogonadal men following prostate cancer is good or bad. Can you please comment on what the latest research is? And is it true that different cancers react differently to testosterone therapy? Obviously, it is helpful for erectile dysfunction.
Yeah, look, that's a really good question. Fortunately, only a small group of men will have hypogonadism. And what we mean by that is their testosterone levels are naturally low, maybe because they've had surgery or they've had chemotherapy or something in the past causes them to have low testosterone. So really my impression of that, or my understanding of the evidence, is that it's not harmful to be on testosterone replacement to just give you the normal level of testosterone, like other men that don't have that problem would be. Prostate cancer, and we're talking about prostate cancer that's being cured here, that's not on drugs like Zoladex, being on those medications, testosterone replacement, is very unlikely to cause a problem in the long term.
Next question is, after my surgery and radiotherapy, I had Peyronie's disease and penile shrinkage. I never hear anything about this. Comments on this, please.
So thank you for the question. The research is saying around about 1 in 6 men after prostate, like a removal of prostate, has Peyronie's disease. And
Excuse me, do you just want to explain what that is? Because a lot of people won't know what that particular disease is.
Sure, I'll give it a nudge and Giovanni can correct me if I haven't got it quite right. But it's where there is scarring within the sheath of the surrounding the penis. And that scarring is like a thickening, so that and so that when the penis tries to expand, it can't expand where the scarring is, and you get a kink in the penis, a bend, and that bend is normally to the left or the right, but it can go up and down. So that what you want is a nice hard straight erection, but with Peyronie's disease it goes off to the side. It can be mild, it can be severe. It is often associated with some pain, and initially you might feel a hardening, a lump on the side of the penis. It can be diagnosed just by feeling that, or you may go and have an ultrasound to diagnose the scarring on the penis. And the main treatments that I understand is you can, as a physiotherapist, there's been some very good evidence out there that ultrasound treatment can help to break down that scarring. And the treatment that I do with my patients, I do it twice a week. It takes about 5 minutes to do it and about 10 minutes on that scarring. And then we use a vacuum pump to try and stretch out the penis in the meantime as well. And then there's surgical approaches. There's an injection called Xiaflex, and you can get stretching devices, traction devices. Their evidence is so fantastic. But I'd love to hear Giovanni's answer too.
Yeah, I think it's probably not totally understood the Peyronie's as to why that happens. The shrinkage is a few factors. One of it is the use it or lose it kind of thing. So what we call atrophy just shrivels up because it's not being used. When the prostate's removed, a slide I don't know if you recall I showed earlier on, there is a physical gap. When the prostate's removed, the bladder and the urethra, the water pipe, have to be brought together again. So some men do notice that the penis does seem to be shorter, and it's probably a combination of both of those things.
I find it interesting that there is zero help offered post-op if your procedure didn't go well, other than say how to do injections. In my case, it's a dead duck due to a botched biopsy and excessive scarring, but no help offered with the emotional side. It seems odd given the situation compared to, say, breast cancer. And then it goes on and says, Pharmac has never received an application to subsidise Cavaject or Viagra. Maybe this is something we should consider. And in my case, straight to Cavaject. I doubt if this is sustainable or that any man manages multiple years on this. Would you like to comment on that?
Well, let me just say, about the support. I think it's true that, I often say we're sort of 25 years behind where breast cancer was when it was really on the map. And prostate cancer is getting there, but it is really taking some time for some of those, what you call psychosocial or some of the surrounding support issues to be really addressed. The whole issue of survivorship is coming into focus much more now, and you'll see a lot more develop in that. Obviously, we as a foundation are trying to do what we can with support in that area and even holding webinars like this, but it will take some time, particularly for the powers that be in the Ministry of Health and things to actually deal with those. And a lot of it will actually come from grassroots level, people talking about this sort of thing and putting pressure on the politicians and the medical fraternity to deal with that.
I think that's right, Graham. I mean, breast cancer has been extremely populist topic. You recall people, was it 5-6 years ago, Herceptin, huge, public outcry, protests, people turning up on Parliament steps, and the politicians listened. And it will take something like that to encourage funding for prostate cancer side effects because it's expensive. And unfortunately, it comes down to cost. We're in a system where money is not unlimited, and erectile dysfunction treatments are expensive. But it doesn't mean to say they shouldn't be funded. And I think there's work to be done.
By 3 years on with no activity, is it too late to recover, or can remedies still be effective? Sharon, would you like to answer that one?
Sure. Look, I'm an optimist. And I think after 3 years, you're really in that tough zone of, we kind of say 2 to 5 years is really optimistic. But I'd like to know, what you've tried first, and have you got a good GP to talk about some options, and your urologist. I think also is looking at the mental part of that as well, is your emotions towards that, the grieving process as well. I also would want to know what type of treatment you had, nerve sparing or not, those types of things. But I think is finding a pelvic floor physio that understands men's health, finding a GP that's willing to talk you through the options and what sort of treatment you had, and going from there would be really important.
I think the other thing I can add to that is, just because we're urologists doesn't mean that we're all experts in erectile dysfunction too. So I actually personally don't treat prostate cancer. That's not my expertise, but my expertise is in survivorship, so erectile dysfunction. So just because the surgeon that did your prostate cancer surgery doesn't seem to be talking to you about it, doesn't mean that you couldn't ask to see another colleague perhaps that can as well.
There's quite a number of questions along this theme. I asked many medical people and none helped with advice with penile health. It's frustrating. I had non-nerve sparing a year and a half ago. If I hadn't used a pump since then, is it too late now? Will my penis now have fibrosis? How would you know? That's a good question. What would your answer be, Sharon?
So first of all, I feel really sorry for you, that you didn't get the information that you could have had, but you said non-nerve sparing, didn't you? So yes. They took the nerves out. Okay. So therefore, I think for you, you're going to have to go down the more of the radical track. But there's a few options that you don't have because you don't have the nerve sparing. Again, I think it's the same thing. Try and find a urologist that has more specialty, like Giovanni, that type of thing, that can really look through your options. You could still use a pump. A pump doesn't need nerves to work. The medication does need nerves to work. Then maybe it might be looking at surgery. We haven't mentioned ACC, but if you can get ACC cover for treatment injury, which is getting a little bit harder lately, they've changed the thingy, you can get help with pumps and you can get help with surgery, but it is trickier at the moment.
I did find discomfort after using a vacuum pump and stopped using it. I did not buy the pump until 5 years after surgery.
So like we said before, pumps can be painful, and it's often how you use it and the aggressiveness that you use it with. And maybe after 5 years, if your penis hasn't had any expansion, then potentially those tissues are quite tight. And so you'd have to go really, really gentle. You might want to look at also the type of cuff. So some of the cuffs that go on the end of the pump can be really quite tight. So if you've got a wider penis, this pump might hurt once you've expanded and be too tight. So you can get different cuffs to help with the comfort. And then it's also how fast. So this one is quite gentle with its increases of tension, whereas other pumps can be quite aggressive with their increase in tension.
Do you offer brief online advice and sales, and do you have a link to your site?
Oh, okay. Yeah,
Yes,
so
you can give a little promo there, Sharon.
Okay, I'm allowed to. So I am a pelvic floor physiotherapist, and I've been working it for 19 years now, exclusively in the pelvic floor. So I do offer online consultations, and so that's available through my website, which is www.restorephysio.co.nz. You could just simply put in pelvic floor physio Nelson, and I'm going to pop up. So I don't mind doing online consultations, and my website is also available. The online shop is on that same website. So one of the tabs along the top says online shop. And then down the left-hand side, there's all sorts of categories because I sell women's products as well as men's products. And one of them will be men's products. And down there, you'll find the vibrator and the pumps and lube and a clamp for a leakage of urine. So I also don't mind receiving phone calls saying, look, I'm on your website and my gosh, there's too many. What would you recommend? And I don't mind receiving phone calls at all. I have the most amazing yarns from men from the top to the bottom of the island, and they often can't believe that talking like and telling me stuff. They have to pinch themselves. I think that they're telling me what they're telling me. But it's a real privilege to work in this area, and I'd be more than happy to have a chat.
Sharon, there's also a couple of questions asking how much do the pumps actually cost? And I'm presuming that that's all on your website, but do you just want to give a bit of an indication?
Yeah, and it really depends on the simplicity of the pump and how whether it's more of a sex device, whether it's a medical device. So some of my patients, they didn't have great sexual function beforehand. And so what they're trying to do is keep their options open. If you don't use it, you will lose it. Unfortunately, that is true with erections. So some of them just buy this basic one here for $70, and they just keep the penis healthy by moving that blood around and stretching the tissues. Some of them actually, I have a patient at the moment who's loving his bath mate. He's finding it a lot stronger and can get a better erection from it. And they are around $209. The Vacurect sell for around $400, and that comes complete with the rings attached to the base, which is super handy. And the Osbond sell up to $900.
If one is on Zoladex, are there any devices or treatments that are effective for erections?
Yeah, that's a good question. So all of the options will still work if you're on Zoladex. Zoladex is the medication that lowers the testosterone level. So Viagra, injections, vacuum pumps, surgery, they're all perfectly good options to explore if you're on those medications.
This person has asked, I am on hormonal treatment and night erections have stopped.
That's right. So that's one of the realities of being on hormone treatment, is it removes your testosterone. Those natural erections that you get automatically at night time, often men wake up with them in the morning, they will disappear.
What is the percentage of ED being psychological rather than medical?
I don't know that I have the answer for that off the top of my head. Sharon might. One of the things I can say is that a good way to figure out if there may be a psychological component, because some men do wonder, is it me or is it my body? If you are waking up in the morning with erections or getting those erections during the night, that suggests that the connections, the physical stuff is happening okay. and there may be a psychological component. Part of that psychological component is worrying that you may not be able to get an erection. And particularly if it's a new partner, thinking, oh, I don't think I can get an erection. It's very hard to actually get a good erection if you're worried that you might not get one. But if you're getting them during the night time, that's a positive sign that it's that the plumbing or the blood flow is working.
There's a general notion that having an injection may be the best assistance to a healthy erection. Is this available on the NHS or only privately? Yeah, he's saying NHS, but I'm presuming he's meaning for New Zealand here.
Yeah, the injections aren't funded. In terms of effectiveness, surgery is the most effective, and then injections are probably the next. And then it's, I'd put vacuum pumps and drugs on a similar kind of level.
Where does one get testosterone prescriptions from? Can you do that from your GP, or is it from a urologist?
GPs can do it. Urologists are probably less likely to do them, actually. Endocrine specialists can do them as well. I wonder whether he means a testosterone prescription, though, because we haven't really talked about testosterone so much tonight.
No, we haven't. It's a little hard to decipher from this question.
Yeah, we did a webinar on incontinence that was shared with Anna Lawrence and the Continence Society. So I think we're going to have a link on our website to that. We were just discussing it at the office the other day. So get in touch with us and we can certainly provide you with a link to that. It was a very good presentation by Anna on urinary incontinence. Yeah.
Can you address the issue of climacturia, please, and just explain what actually this is?
Do you want me to take on that one?
Yes, Sharon, you start on that one if you like.
Okay, so climacturia could be described as arousal incontinence. So it's when there's leakage of urine with an orgasm, which can be really devastating for you and your partner. And so the thing I think is the rate is around about 50%, but of men will experience this, but some studies are as low as 50, and some studies even go up to 93% of men will experience it at some time after cancer treatment. It's worse within the first year, and it should improve after that. Also, the studies show that it can be as much as a few drops. It can be as much as 30 mils, and it can be more than that as well. I think practically there has been good research to show that, again, pelvic floor exercises. So the stronger your pelvic floor muscles are, the less leakage you may get. The other things that are shown to be like practical stuff is that you may want to try sex in the shower, so that where if you did leak, it's not so much of a big issue. Go and have a pee before sex, so that your bladder is as empty as possible. There are things called masturbation sleeves and condoms you can use, so that if you do leak urine, it leaks into a reservoir and you just get rid of it. It's not leaking somewhere. There's also a thing called a liberator throw. Now this is a bit of a wild one, and it's just this plush, luxurious but waterproof blanket. And so it is a sex industry type of thing. But if you had that throw on the bed, or the couch or wherever, wink, wink, nod, nod, if you leaked into it, it's designed to take urine, and it can take a lot of urine. So if you're having more leakage, that'll give you a bit of confidence. Rings can help to reduce leakage of urine, and also positions for sex. So if you're having a position, you're in a position, say you're on top and your tummy is pushing down on your bladder, you're more likely to leak urine. So positions where maybe your female partner's on top, or you're from behind, so that the bladder isn't getting pushed. The last thing I'll say about it is that if you're taking, there's certain foods and drinks that can make the bladder more contracting. So things like coffee can make your bladder more irritable, alcohol, citrus products, tomato products, and bubbles. So if maybe avoid those types of drinks and food before having sex, so your bladder's a little bit calmer.
I think it's just that use it or lose it thing, really. It's not so much that it's getting damaged because you're not using it regularly. It's just, if you don't use it, you'll lose the ability, whatever it is, whether it's the tablets, the injections, the pumps. Your best outcome is to get into it early and to do it regularly.
Regarding the first diagram in tonight's presentation, so this is Giovanni, optimal testosterone, I feel my state is like the person on the left-hand side of that diagram, putting on weight and loss of condition and at times overall confidence. Should I get my testosterone checked, and where do I go from here?
I would. Yes, I think there's no harm in getting your testosterone level checked. And if you're having some symptoms as well, like he's described, having testosterone replacement may well be the thing to do. And your GP can do that. Don't need to see a urologist necessarily.
Okay, well, we'll start to sort of wind this up. There's been some great information there from you presenters tonight and through the questions as well. Just one point I want to make is that for men who don't manage to recover from erectile function, there are other forms of intimacy, and maybe that's another whole webinar that we look at some stage. And I just want to say sex therapists can help with that. And we haven't really even talked about sex therapists tonight, but that's another whole discipline that can help men and their partners in this whole area as well. So look, Giovanni, Sharon, any final comments before we wrap up?
Well, I've learned a lot from Sharon, so I'm sure that I hope all the audience has. Look, it's been thanks for giving me the opportunity to be here. It's a really interesting topic, and it's not covered enough. Men, not something as Kiwi blokes that we tend to want to talk about, and I think that's changing. You know, I think the prostate's maybe the third or fourth time I've done a talk through the Prostate Cancer Foundation. It's really great, Graham, that you're promoting this as an issue and putting a lot of these different options out there for people to be able to explore.
I think from a physio point of view, the research would say that men who do something proactive to maintain erectile function or aim for the best erectile function do better in the long run, quality of life wise. So be proactive. Look, some of you men will be in way different journeys. Some are early in the journey, some are down the track. Hand on what you've learned along the way. Encourage other men if you're down the track to be proactive. Seek help. Don't give up. If you still, like tonight, if something's gone, oh, I haven't tried that, maybe that's my option. Go and find someone who's not going to be embarrassed, but is willing to talk to you through it. Get into those pelvic floors, nuts to guts, shorten your penis is your new cue. Tell everyone. It's the latest saying in our physio circles. And by all means, jump on my website, have a look, and contact me if you need my help.
You know that we at the Foundation are there on the phone ready to take calls on our 0800 477 678, or you can get to us through our website, prostate.org.nz, or the Facebook page. You'll also find on our website a online community forum as well, where you can have discussions with other people about these sort of issues and other issues that come about through prostate cancer. We've also got a YouTube channel, and there's quite a number of presentations. Giovanni's done others for us, as he mentioned, and various people have done presentations over the years, and you'll find those on our YouTube channel. And of course, we've got a strong network of support groups around the country. Currently, there's about 38 of those groups. Raymond heads up that service that we provide. And these are places where you can discuss these sort of topics in a peer-to-peer situation and get peer-to-peer support. So the details of those are also on our website. It's not a group near you and you've really got the inclination you'd like to get one going, well, we'd love to hear from you. We're always looking to expand that network. So Giovanni and Sharon, I just want to say a really big thank you to you guys. You've been really open, really honest. Your expertise is really appreciated. So thank you very much for joining us tonight. And to everybody, thanks for joining us. There's been a really big attendance on this webinar tonight. Over the next couple of days, we'll send you an email with a link so that you can see the webinar recording of this. And we'll also send you a survey, because we really appreciate getting your feedback, and so that whenever we do these, we can improve them and do them better next time. So thanks for joining us. We wish you well. Keep safe, and good night. Thanks very much.